Thanks very much, Tony. And thanks to the MS Canada for inviting me to talk about everything in 18 minutes, which is going to be quite a challenge. So I had to pick on a few things that I felt were real game changers and driving pretty well what many of you are doing in terms of research. So to try to understand and put that into perspective, and hopefully I'll be able to accomplish that. So this paper came out now a couple of years ago from the Clinical Trials Committee, and they were focusing on where are we going, what should we be looking at, and what are the mechanisms that are driving this disease, and maybe we should be focusing our attention at these individual mechanisms. So, I mean, I urge you to have a look at the paper. It's a busy slide, but we've heard a little bit about this already from Professor Lassman, where he spoke about the focal lesions, he spoke about the evolving lesions, a little bit about how we judge these, and then I'm going to walk you through a little bit about this process and then introduce probably a family of drugs that may actually be addressing this. So in the past, people have shown these little cartoons about MS and how it evolves. And because we're neurologists, we're very good at describing things. And most of the diseases that we treat were based on phenotypic descriptions of how people evolve. And so for the most part, when you think about MS, it went through a phase where people had relapses and remissions, and then after a while, you didn't appreciate any more relapses, but you started to see people just sort of soldier on with a progressive disease. So it was sort of like one phase and the other phase, and that's where all those phenotypic terminologies came in for years now. We talked about a relapsing remitting phase and a secondary progressive phase or a primary progressive phase. But you know, pretty well now we've done away with that because our understanding is whether or not a patient has a relapse doesn't indicate that they have a disease. You just heard an elegant presentation by Helen Tremlett about how this disease actually evolves long before it ever shows itself clinically. So our concepts have really changed. And this is sort of an adaptation of a similar type of diagram that Amit Bar-Or drove years ago. And he was pushing this whole idea that although this may be a relapse kind of presentation of MS, the progressive phase, which we see later, doesn't start later. It actually starts early, and probably when the disease begins. And so people go through this relapsing phase, and then that sort of relapse part of the biology disappears, and you see the progression. But we're trying to figure out biological mechanisms that are driving this. And it seems to be that this relapse biology is driven by what we're calling peripheral initiated inflammation. And that the more progressive phase, driven by compartmentalized inflammation, or if you're in the immune world, the peripheral inflammation dominated by the usual culprits, the B and T cells, part of the adaptive immune system, and the compartmentalized inflammation driven by more of the innate immune system, such as microglia. So why do we have patients presenting differently? Part of it is how much of these individual components are so evident, but also we have to recognize that many patients have different ways of dealing with disease. And they have compensatory mechanisms, the brain's very resilient, there's redundant pathways, there's plasticity, all of those things try to protect the body and don't allow the expression. And so when you start to see the expression of the disease, you're seeing on the one side what's the inflammatory network that's driving it, but also on the other side, the inability of those compensatory mechanisms to prevent the expression of the disease. So regardless of what you're doing in terms of your research, you're probably dealing with something on the inflammatory side or something on the regenerative side or some of these plasticity mechanisms or even the possibility that there's some repair. So here's the two compartments. We know that on the left side, the peripheral inflammation driven by the usual culprits, okay, that leads to inflammatory events. And in the end, if you've had an event, you can fully recover from it, but many people do not. And you're worse after the attack. And people have now turned that RAW, or relapse-associated worsening. On the other hand, if you have this progressive nature of the disease, that occurs irrelevant or irrespective of the attacks. And what has that's been now termed progression independent of relapse activity. So those are important terms to remember because our concepts now have changed. And PIRA is not something that occurs later. PIRA starts probably even before the first attack, because that process is ongoing. People have used this term smoldering MS, and one of the reasons is because now we've coined it, a term, but how do we actually look at that? And what are the drivers of smoldering MS? It turns out there's probably a few things. You already heard about the prodrome and some certain comorbidities that may be driving it. There are immune mechanisms. There are demyelinating mechanisms. There are compensatory mechanisms. And superimposed on all of this, unfortunately, is aging. And as we age, our ability to deal with immune diseases changes rapidly. And we always, when we're dealing with progression, there's that superimposed nature of someone just getting older, and your immune system and your nervous system starts to falter. And your ability to deal with that is all based on your reserve. And so if you've eaten up that reserve very early on with inflammatory events, you're going to have less ability to stave off that kind of aging-related phenomena as you get older. So that's why when we see young patients, and they're just so resistant to going on therapy because they bounce back from attacks. I feel great. They don't realize what's happening. They're eating up their reserve, and 20 years from now, they're going to be coming back going, oh, why am I weaker? And because they've used up that reserve. So the kinds of pathological drivers here are these immune events, some of which you've already heard about, right? The focal MS lesion, the meningeal follicles that may be driving part of this disease. On the far right, that smoldering rim, iron-lated rim that Professor Lastman talked about, this scarring process that's pushed by just gliosis in general, and then on the whole, just aging on the nervous system that's going to drive it. And so another busy slide, but again, you look at these pathologies, and chances are one of the animal models you work with or one of the other types of analyses that you're doing is going to be addressing one of these drivers of overall MS progression. And I think some of what Jennifer was talking about may be directed to the meningeal B-cell rich aggregates, which are driving this disease. But the reactive microglia, that's probably the ones that need the most work right now, because that's the area of MS that's the highest area of unmet need. So that's what's underlying PIRA. So how do we measure PIRA? How is this detected clinically? And so I'm going to talk just briefly about these four elements. The EDSS, which we all hate as clinicians, but since some of you are not, I'll just talk briefly about it. There are other assessments, which I won't get into. These are all based on patient-related outcomes or cognitive assessments. There are clear imaging parameters that are now addressing some of this idea of PIRA, and you'll even hear later about fluid biomarkers, but I'll just introduce it briefly. So this is the scale we love to hate. It's shown here like a linear, nice equal steps. That is anything but true. This is a composite index, and the difference between one point or another is actually quite complex. But nevertheless, I'm just going to familiarize you with it. That's the EDSS, and the components of it are shown below. And so people have used this to try to understand where PIRA comes from. And you'll see a lot of recent publications that actually talk about this, a very large group of publications that have looked at PIRA in early MS, and all of this is now reflected in these studies that have literally been published in the last year. When you look at how people worsen, the blue is how much do they actually get worse because of residual deficits from attacks versus all this other disease that's running in between attacks, which you see there in red. And probably one of the best cohorts, I'm going to show you in a minute, there's been several groups. This is from the University of California, and then the Swiss group has looked at the same thing. And finally, the largest CIS cohort was in Barcelona, and they took these patients and followed them. They've followed them for almost 20 years now. And in their story here, the gray areas you're seeing here, these are relapses, clearly defined. These are patients who suddenly get worse. And then they defined a period of time followed by, there's no relapse, but if you got worse during that period, that was considered a PIRA event, as you can see here. So the relapse are showing, the PIRA events are showing, and when they did their full analysis and they looked at now reaching a certain milestone of EDSS-6, which if you don't remember from that scale I just showed you, flash subliminal message of what EDSS is, it's actually a critical point for patients because they lose their independence of walking. And at EDSS-6, they become absolutely dependent on at least a single device. So what about that? What's driving that? Well, you can see here that the raw group is the orange, and those are the patients who are getting to EDSS-6, but the patients who have PIRA, they're getting there a lot faster. So this whole concept is that there's an underlying immunological process driving this probably compartmentalized biology that is the substrate for this progression that occurs later in life, but actually that manifests later in life, but is present right from the outset of the disease. So one of the things we can do is you can measure these, and you're going to probably hear about this a little bit later, this notion of a slowly expanding lesion, which is probably the most representative now of this evolution of PIRA, and the association turns out to be rather high. We have other ways of looking at this now. You're going to hear a lot about central vein sign coming up probably next year as a way of being absolutely specific that lesions are due to MS because they surround, it's a perivenular inflammatory response, and now we can see the little vein in the middle. And there's something called the paramagnetic REM lesion, which is also very specific to MS and is probably representing that slowly expanding lesion. And if you're really have the ability to want to look at the microglia, there are techniques out there to be able to measure these. They're very technically difficult because it requires a tracer and a PET machine, but you can see what's happening to the microglia, getting an idea of what's going on in vivo. All right, what else can you use? Well, we've done a lot on neurofilament light chain. You'll probably hear about it later, but a baseline neurofilament light chain almost always predicts that these patients are going to do worse. And you heard from Helen that's been already affected in the prodrome, that these are lower levels. And this on the far right is work from our own Simon, who's here, who's looked at our mesenchymal stem cell patients who actually had quite a bit of activity and were followed very closely for a year. And the lowest neurofilament light chain to begin with predicted that those were the people who are more likely to have an attack and more likely to have T2 activity on their MRIs. So you can use biomarkers. Probably for progression, we're going to have to use another biomarker like GFAP, which gets at a little bit of what is the scarring process. And probably as we go forward, a mixture of biomarkers will likely inform on this disease progression. So in order to treat this disease, we can't ignore the two biologies. On the one hand, we have all these drugs that are addressing the focal lesion, the peripheral inflammation, but what do we have that gets into the brain that can address the so-called compartmentalized inflammation? So let me introduce you to the BTK inhibitors. So BTK turns out to be an enzyme that is present throughout, but also if you look at who's expressing it, B cells, monocytes are important. And so if you have an inhibitor, you can get at these two cell types, but inside the brain, you can now address the cell types. And these are small molecules that get into the brain, unlike the majority of the medicines that we have today to treat. So how is this beneficial? Well, on the peripheral side, we know that the B-cell therapies are highly effective for reducing some of the inflammation, and the BTK inhibitors can actually interfere with the processes that you see there on the left. But potentially, when it gets behind the brain, the barrier, it can affect some of that so-called smoldering inflammation that may be driving then the progressive nature of the disease. A very busy slide, but it's labeling all the different treatments that we have today that are not addressing this process, you see, because there's the microglia, and there's only one that's getting in there is the BTK inhibitor, and then outside it can affect some of the drivers of the peripheral inflammation. So right now we have a bunch of these in clinical study. There's the only one that's not really in Canada is in the orange there, but all the others right now, and the green one probably is not going to go forward, but the 4 on the left are very likely going to be producing results in the coming years, with the one on the far left plan to reveal their results in the early part of 2024. They have some differences amongst them that are pharmacologically driving perhaps how they're going to do clinically, but all of that is quite hypothetical, and we await the results of the phase 3 trials to be absolutely sure. So in the last 18 minutes, I've had to try to impart upon you our change in our thinking about MS, that this is a progressive disease from the minute we're sure that a patient has the disease, that the drivers of the disease process are a little bit different, but they're overlapping, and that the current therapies we have really only address this peripheral inflammation, not the centralized inflammation. That may be the driver of what we call clinically PIRA, the progression independent of relapse activity, and at least we have one new family of drugs that might be getting at the compartmentalized inflammation, the BTK inhibitors. And you'll probably hear more about these as times to come, but at least maybe you can now look at what you're doing in terms of research and put it into perspective of what we need. So thank you very much.